So this section will be about diarrhea and about fecal incontinence. Diarrhea is frequent loose or liquid stools. We can have acute or chronic diarrhea. Acute diarrhea is frequently caused by some kind of gastroenteritis that may be viral or bacterial. It can be caused by antibiotic therapy. Antibiotics, especially broad spectrum antibiotics, will kill the normal flora in the gut and lead to overgrowth of other types of bacteria and cause diarrhea. And acute diarrhea can also be caused by ingestions of excessive or a sudden increase in fiber or simple sugars. Chronic diarrhea is can be caused by inflammatory bowel disease. Those are serious chronic inflammation in the bowel that usually involves not just diarrhea, but bleeding and potentially serious complications, bowel perforations, scarring. So that can be pretty serious, or irritable bowel syndrome. And people mix those things up, but irritable bowel syndrome is associated with chronic abdominal pain and diarrhea or constipation or both, but not with bleeding and not with the severe inflammatory damage done by inflammatory bowel disease. Inflammatory bowel disease is ulcerative colitis or Crohn's. Chronic diarrhea can also be caused by food allergies or intolerances, especially if the patient is not aware of what their allergy is. Management, if it's an infectious cause, we obviously want to identify and treat that. We want to help that patient have good perineal and skin care to prevent breakdown. Medications can be given to slow peristalsis. They really should not be given in infectious diarrhea or antibiotic related diarrhea that we don't want to maintain the infection longer, but they can be helpful in patients with chronic diarrhea. We want to monitor that patient's hydration and electrolyte balance. We can recommend probiotic foods to reestablish normal flora, yogurt, buttermilk, kefir, things like that, kimchi, sauerkraut, all of those foods that will replace the gut flora. That can be helpful, especially if someone has maybe a gastroenteritis and they continue to have ongoing diarrhea for a few days after they feel better. Frequently, that's because their normal flora is out of balance, and restoring that balance can help. Patients who are on antibiotics, we can proactively recommend probiotic foods. Patients may also be prescribed or may purchase over-the-counter probiotic tablets or capsules. Fecal incontinence has several causes. It can be caused by diarrhea. Someone who's not normally incontinent may have diarrhea severe enough to cause incontinence. There are medications that can cause diarrhea severe enough to cause incontinence. It can be caused by fecal impaction, like we talked about in the previous section. It can be caused by decreased sensation or sphincter control. So someone who has neurologic damage to the sphincter or to the rectum, so they have decreased sensation of when they need to have a bowel movement, or decreased control of that sphincter. Or it can be caused by a cognitive or mental health disorder that causes the patient to not recognize the need to go or the appropriate place to go. The management of fecal incontinence is based on the cause. Patients who are cognitively impaired, if we provide toileting rounds and take them to the appropriate place, we can decrease incontinent episodes most of the time for them. Chronic constipation can be treated with stool softeners and bowel training after that fecal impaction is resolved, and that can improve incontinence caused by that cause. For diarrhea, we want to treat diarrhea, but we should not be suppressing diarrhea due to infectious disease for at least the first 24 hours. We want to protect the skin, and there are some devices that are used to collect fecal matter in patients who are, usually they're used in patients who are unconscious. There are external collection devices that fit around the anus, sort of like a stoma device, and there are internal collection devices that have a large bore tube. It's soft, but it's a large bore tube and it's held in place with a balloon. There are risks to both of those. External collection devices tend to have stool leak under them and cause skin breakdown. Internal collection devices, especially if they're used longer term, can cause damage to the sphincter. Both of those are going to be most effective if the stool is liquid or very, very soft. They're not going to be very effective for hard stool. We also, for those patients who have, maybe if someone has a neurologic cause of fecal incontinence, they may manage that by scheduled enemas to clean out the lower bowel at specified times. And you'll see patients sometimes who have paraplegia who use scheduled enemas. Someone has decreased sensation, they're likely to have incontinence, but they're also likely to experience constipation. And so that may be a bowel schedule or a bowel routine can actually decrease the episodes for both of those. In the next section, we're going to talk about flatulence and hemorrhoids, and then we're going to move on to bowel diversions.